Good afternoon, colleagues. This afternoon I'm going to be moderating with Professor Moshabela. I'm Oathokwa Nkomazana from the University of Botswana. And then Prof. Moshabela will introduce himself.
Good afternoon, colleagues. My name is Mosa Moshabela from the University of KwaZulu-Natal in South Africa. Welcome to the session. Thank you very much. Oathokwa, you can go ahead, introduce the session. Thank you.
Okay, so the session this afternoon is about epidemiological transition and disease burden of COVID-19, non-communicable diseases, HIV, TB, malaria, and Ebola. And so the first presentation will be from Thembelenkosini Nxumalo. And they will be presenting on the perceptions and understanding of the coronavirus pandemic. And it's a qualitative study of primary healthcare practitioners in KwaZulu-Natal in South Africa. Please go ahead and introduce yourself briefly. You have 10 minutes.
Themba, open your mic and introduce yourself and put up a presentation. Thank you.
Good afternoon, colleagues. I hope you can hear me now.
Yes.
You can put on your video if possible, so we see you.
I was trying, it says like you cannot start your video because the host has stopped it.
Okay, no problem.
No problem, go ahead.
Okay, let me start.
You can share your video now.
I can start the video now. Okay. Okay, sorry. Good afternoon, colleagues. I will be presenting today my findings from the study entitled Perceptions and Understanding of the Coronavirus Pandemic, a qualitative study of primary health practitioners in KwaZulu-Natal, South Africa. Firstly, let me introduce myself. I am Dr. Nxumalo, as my moderators have introduced. I'm a fellow for developing research, innovation, localization, and leadership in South Africa. I'm in the HIV/AIDS scientific track, and I'm also an honorary lecturer at the UK's College of Health Sciences. I'm presently involved in the front line as a healthcare worker in one of the primary healthcare facilities in KwaZulu-Natal. So I'm involved with management of patients with COVID-19 at a primary healthcare level. So that is where the study originated. It's not allowing me to proceed with my slides. Okay, so that was my personal profile, and that's my study. So a bit of a background. In December 2019, a type of novel coronavirus caused by SARS-CoV-2 has spread rapidly around the world, and the escalating numbers of infections and related deaths resulted in the pandemic being declared a public health emergency of international concern. Now, in South Africa, case 0 was detected in March 2020, and since then, the numbers of infections and deaths have escalated to such that South Africa is presently the epicenter of the outbreak in Africa. To date, more than 2.4 million COVID-19 cases have been confirmed in South Africa, and more than 72,000 related deaths have occurred, according to the National Institute of Communicable Diseases. As from February 2021, more than 40,000 healthcare workers have been infected with COVID-19. In KwaZulu-Natal alone, more than 5,000 healthcare workers have been infected. Now, with the knowledge or understanding that the R0, which is the number of people who will become infected from each infected person, can be heavily reduced depending on what the nation does to curb the spread of the virus, it makes sense then that the National Department of Health, including KwaZulu-Natal Department of Health, has adopted several primary prevention interventions to mitigate the spread of the virus. In light of that, primary healthcare practitioners are at the forefront of the pandemic in terms of screening, early detection, and clinical management. While a study has been conducted on healthcare workers' perceived level of confidence regarding working during the COVID-19 pandemic, there is little empirical qualitative evidence on how primary healthcare practitioners have come to perceive and understand the COVID-19 pandemic, especially in the context. So the aim of the study was to explore and describe the perceptions of primary healthcare practitioners regarding the COVID-19 outbreak in KwaZulu-Natal, South Africa. The main research question was, what are primary healthcare practitioners' perceptions regarding the COVID-19 outbreak in South Africa? And a descriptive qualitative approach was used as the research design. We sampled 4 satellite clinics in KwaZulu-Natal, South Africa during the first and second wave of the pandemic. And the population of participants comprised of healthcare workers, namely nurses, doctors, clinical associates, pharmacists, and social workers. The purposive sampling method was used, and a total of 20 participants were recruited for the study. Ethical approval to conduct the study was obtained from the University of KwaZulu-Natal's Biomedical Research Ethics Committee and the KwaZulu-Natal Department of Health Research Ethics Committee. Individual in-depth interviews guided by a self-developed interview schedule was used to collect the data, which were recorded using audio tapes and transcribed verbatim, and content analysis was used to analyze the data thematically. During the data collection processes, strict adherence to infection control procedures were put in place to ensure compliance with behavioral interventions to curb the spread of the coronavirus during wave 1 and wave 2. So the emerging results were that there were 44 categories of description in participants' perceptions regarding the coronavirus pandemic. There were pre-pandemic perceptions, which were perceptions before the pandemic occurred in South Africa. There were perceptions during the occurrence of the pandemic in South Africa, and there were perceptions regarding preparedness and perceived community attitudes regarding COVID-19. In terms of the pre-pandemic perceptions, the main subcategories were fear, denial, ignorance, and anticipation. And then in terms of the pandemic perceptions, there was perceptions regarding the nature and clinical outcomes of the disease, misperceptions regarding COVID-19, unrealistic expectations. Perceptions regarding the preparedness were related to poor preparation by the Department of Health, perceived lack of personal preparation on the part of primary healthcare practitioners, and then it was healthcare workers' personal expectations. Regarding community attitudes, perceived community attitudes, they were positive and negative. And then now I will present to you some of the substantiating statements for just a summary of categories and subcategories. So in terms of fear, participants number 18 cited that it was terrifying in that it included sudden death and statistics from other countries as well. So it was frightening back then. So that's quotation serves to support the notion of fear, which was strongly found in the study. Then it was unrealistic expectations, and you can see the participants' responses there. And then perceived poor preparation. Participant 13 says, when it comes to planning, after seeing that something is happening in China and other countries, there was no adequate planning to prepare for when the pandemic comes in South Africa. So in the discussion, as I said, the main finding was that there was fear, which was attributed to, from the findings attributed to the influence of media and general social media about the nature of the COVID-19 pandemic as it was being portrayed in other countries. So the fear was also reported in other findings, in other studies, namely the one that looked at the levels of concern among healthcare workers during a previous Middle East respiratory syndrome outbreak. The unrealistic expectations and perceived poor preparation highlights possible gaps in the health system's disaster preparedness strategy. And overall, there were negative perceptions regarding the outbreak of the COVID-19 pandemic. This is a cause for concern as practitioners may not be able to provide optimum quality healthcare as a result of such negative perceptions. The key lessons learned are that healthcare workers are at a risk of developing mental health issues due to negative perceptions regarding the COVID-19 pandemic and the lack of accurate information and preparation for working during the pandemic. Poor preparation could further compromise job satisfaction and service delivery, and therefore support in the form of clinical education and training is necessary for healthcare workers at primary healthcare level in order to provide optimum quality of healthcare during the pandemic. And also ongoing surveillance and disease monitoring are essential at PHC level for preparation of healthcare workers for an outbreak. And then the limitations of the study were that the sample size was only 20 and the nature of the qualitative study didn't allow for generalization of the findings, and the choice of individual interviews as the only data collection method. I would like to acknowledge DRIL, Developing Research Innovation, Localization and Leadership in South Africa for supporting the study. Thank you.
You really are spot on in time. Well done. Professor, I think if we get any time left, we'll allow for question at the end. So I'm going to let Professor Moshabela to call in the next speaker.
Thank you. Tamba, you can take down the presentation. Thank you for your presentation, much appreciated. I'd like to invite the next speaker, Shane C. Quinonez, on the topic of use of family history as a risk assessment for non-communicable disease. If you can share your presentation, introduce yourself very briefly, and go straight into your talk, we'll appreciate it.
Okay, can you hear me okay?
Yeah, you just fine. Thank you.
Okay, and can you see the presentation okay?
Yeah.
Okay, great. Well, I really appreciate the invitation to speak today. My name is Shane Quinonez. I'm a medical geneticist. I specialize in biochemical and pediatric genetics here at the University of Michigan. And I'm going to be talking about a really exciting bit of work I've been doing in Ethiopia with my colleagues listed there. And so the title of this talk is going to be the use of family history as a risk assessment tool for non-communicable diseases. So no conflicts to disclose at this point. So just a basic outline of what we're going to be talking about I won't spend a lot of time on this, but at least want to just highlight the importance of non-communicable diseases, though we are speaking quite a bit about communicable diseases in the last couple of years. I will highlight some of the NCD issues that have been highlighted over the last 10 to 15 years. I'm specifically going to talk about work that I've been doing at St. Paul's Hospital in Addis Ababa, Ethiopia, with a number of colleagues there. And then I'm going to highlight the work using a mobile application. It's called the MyGene Family History app. And the real goal is going to be to take a look at the prevalence and, I think importantly, family history of non-communicable diseases. And I'm trying to make the case that the family history of these conditions is going to be really important when we think about surveillance, management, and intervention strategies, and even prevention strategies going forward. And then I'll talk briefly about some of the expansion of our work in the future. So, again, this is a really busy slide, and a couple of my slides may be a little busy, but this is a publication. This is a figure from a publication that came out within the last couple of years, I think from Lancet, that basically highlighted the importance of non-communicable diseases regarding the sort of years lost or sort of mortality worldwide. So on the left, you sort of see the leading causes from a mortality standpoint in 1990, then in the middle 2005, and then sort of on the right 2015. And I think what you see is that the conditions here in red are those that are communicable, maternal, neonatal, nutritional, and the things that are in blue are going to be non-communicable. And I think you can appreciate, if you just sort of like zoom out, the sort of increase in relative importance of these non-communicable diseases. And I don't think that I'm the first person to say that non-communicable diseases are increasing importance worldwide. So, this is both adult and pediatric problem. And as a pediatric geneticist, I'd be remiss if I didn't mention the same thing sort of happening in pediatric patient populations. And this is initially how I got involved in this work. And again, this is an important figure that has really shown that as a country, you sort of see here a number of countries on the x-axis. On the left, you see the infant mortality rate, and on the right, you see a percentage of infant deaths caused by birth defects, and that is sort of marked out by that red line. And again, the details aren't incredibly important here, but I think the important thing to appreciate is that as a country improves in its management of neonatal conditions, the relative importance of congenital anomalies and genetic diseases continues to increase. And so my work is sort of trying to lay the foundation for the necessary preventative and genetic services that are going to be needed in a number of countries in the next 5, 10, 15, 20 years. And again, just sort of like highlighting a very similar thing. This is under 5 mortality. It's the same sort of thing. And I think what you can appreciate is that congenital anomalies there in blue has sort of marched up every, in this case, 10, 15 years as far as relative importance, and it's only going to increase with time. Same thing goes, you sort of see blue hemoglobinopathies marching up. So this gets us to this, concept of community genetic services, which is basically saying, how can genetic services be initiated worldwide and not just isolated to University of Michigan or high-income countries? And, there are a number of strategies outlined as part of community genetics. I just laundry listed them there, but a lot of these things sort of make a lot of sense. Training health professionals in basic concepts of genetics, using family history to detect genetic risk, which is what we're going to be talking about today, preconception and prenatal care, public education from a teratogen standpoint, care detection for certain disorders, detecting congenital anomalies and referring to higher level centers, and then even newborn screening for certain disorders, including congenital hypothyroidism. And clearly that's a very long to-do list as it pertains to just services to start. But what the work that me and a number of colleagues have been doing at St. Paul's Hospital, this is just a picture of the hospital in Addis Ababa, has been sort of saying, what are the necessary services and questions we're going to have to answer right now in anticipation of instituting these services in the next, like I said, 5, 10, 15 years. And if you sort of ask the question, well, what are the genetic services in Ethiopia at this point? So there's, at this point, no geneticists or genetic counselors practice in Ethiopia. We sort of looked at this and published on this. There's very limited experience and comfort with genetic services and genetic counseling. There is only one in-country lab that's providing genetic testing, which is actually probably pretty unique amongst a number of sub-Saharan African countries, but it's called MRC Ethiopia, and we've done a little bit of a deep dive into their work, and I'll sort of show you a screenshot of some of our publication on that. And so, this work is sort of starting in a country that has very limited established genetic services. And, we sort of have this project that we've come up in terms of MyGene that has a number of arms, but it's really aimed at identifying the epidemiology of, in this case, non-communicable diseases. What are the patient preferences and what are the provider preferences for all of this? And then based on that sort of scaffolding, building the services off of it in the future. And, we've had pretty good luck at assessing a number of those aims over the last few years. And I just highlighted a number of publications of ours that have really sort of looked at some of those needs assessment type data and just sort of like put them here. But I think a large bit of what we've done and what I'm going to talk about in the next 5-ish minutes is this mobile application that I'm terming the MyGene Family History app. And, family history is sort of in quotations there only because at this point, we are using it to collect family history, but we have a number of ongoing projects that is really just utilizing the infrastructure of the mobile application for data collection. But basically it has 3 main purposes. Data collection, in this case, we're collecting family history data, and we're specifically collecting a 3-generation pedigree looking at adult and pediatric non-communicable diseases. And I'll show you the list of the conditions in a couple slides. There is a feature of the app that allows it to output a set of tailored counseling recommendations based on whatever conditions are present. We haven't really utilized that aspect of it that much. We've mostly been collecting more sort of population level prevalence data to get an idea about the conditions present in sort of in Ethiopia and then a couple other places that we're looking at this. I will just put this out there because some people may ask this. This is not on the App Store. This is an app that was designed by myself and a couple of Ethiopian programmers, and we just install it directly on the devices that we're working with. So if you search for it, you shall not be able to find it, which I know is not something that people usually like to hear when I give these talks. And the main question that we were sort of asking is, can the use of family history help with non-communicable disease diagnosis, management, prevention in Ethiopia and other sub-Saharan African countries? And that's a very lofty goal, but this is sort of like what we're shooting for. And I'm going to show you some screenshots from the app. I'm not going to go into crazy detail of the app, but I will say that the app was designed to work in Ethiopia. So a lot of apps that are used here in Michigan, you have regular internet connection, it's constantly connected to the internet, and it relies on that interconnection for function. This app basically doesn't rely on internet access for most of its functions. It can, enroll patients, store data, and then once internet access is available, it uploads it to a sort of cloud-based server that we can sort of access the data through. So just some screenshots of the app questions on the left, and then on the right are the list of conditions that this app screens for. And you'll sort of see there's not many communicable diseases. These are all sort of what would be considered to be non-communicable diseases. The left column are the pediatric conditions, and on the right column are the adult onset or non-congenital non-communicable diseases. We are able to get age information for those adult onset non-communicable diseases. So we not only have the presence of hypertension in a parents, we have the age of diagnosis as well. And so, what we ended up doing is we enrolled a number of participants, specifically 315 adults. We looked at data to try to identify an individual's risk based on their family history. And we also sort of used some data to try to get an idea about risk of NCD development in the future. And I'll just go through a couple results slides and then finish up. But basically, this is just the basic demographic data. I won't go into crazy detail, but about half of the patients that we enrolled had one of these non-communicable diseases, and this is just the adult data. Hypertension, cancer, CKD, and diabetes were the most common. And then I'll get into some sort of this is again, a little bit of a busy slide, and I haven't found the best way to actually represent this, but basically what this slide is showing you is that if an individual has a family member affected with cardiovascular disease or chronic kidney disease, they themselves are more likely to have cardiovascular disease or chronic kidney disease. And so this is the data supporting what we probably all know, which is, hey, if your dad has cardiovascular disease, you have an increased risk of cardiovascular disease as well. That applied to all of those conditions with the exception of cancer, because probably many different types, and then also didn't apply to second-degree relatives, just first-degree relatives. And then the last sort of thing I'll show here is that the other thing that we did is we, based on risk information, identified a number of individuals that were at elevated risk for NCD development based on their family history. And importantly, we did it for cardiovascular disease on the left and then diabetes on the right. Most of those at-risk individuals didn't have those diagnoses at this point. So those are perfect targets for sort of saying, hey, you are at risk for this condition. Let's initiate some surveillance recommendations for you and diagnose you sooner than later. So, just in summary, about half of the patients that we saw at St. Paul's had an NCD. There was increased risk of patients being affected with an NCD if a family member was also affected. There was a significant risk of individuals. So there was a significant percentage of individuals who were at risk for this for one of these diagnoses that weren't diagnosed at this point. So, our goal is to utilize family history from an NCD surveillance and management standpoint in the future. And I think we will sort of think about ways in which we can implement this from a clinical care standpoint in Ethiopia and a couple other countries that we're sort of working with at this point. So a huge thank you to the many, many members of my team that have made this possible. I listed them there, and I am happy to just monitor the chat for any questions that come up. I really appreciate you guys letting me present here.
Thank you so much, Shane. Oathokwa, we can move to the next presentation. Colleagues can just put their questions in the Q&A for us to address. Thank you.
Hi, thank you so much, Shane. The next presenter is Sanusi Musa, who's going to be presenting on the parvovirus B19 infection prevalence in Africa, a 5-year contemporarous meta-analysis. Please go ahead. You can introduce yourself briefly. I think you have to unmute. Oh yeah, you have unmuted.
Yes. My name is Sanusi Musa, lecturer at Ahmadu Zaria, Nigeria, and also as a student at university. Sorry, can you see my? I'm trying to share the presentation.
No, we don't see it yet.
Okay.
Lara, are you able to upload on your side?
To upload it.
Okay, there you go.
Sorry, it's taking time.
Sanusi, you're going to have to speak fast because you don't have a lot of time, right?
Okay, so it's not showing this slide. It's not showing. I'm having difficulty in sharing the slide.
Sanusi, your presentation is loaded. You can see it on the screen.
Some is position on the screen, but me, I'm not seeing it here on my own screen. Maybe it's not.
Okay, Oathokwa, can I suggest that we move to the next presentation and we can come back to Sanusi and we can just ask Clara to assist in terms of how to coordinate this in the background. Thank you.
Okay, no, please go ahead and call.
I have Sanusi's presentation. Can I share it, please?
He's not able to see it, Clara. He can't see
Okay.
it from his
All
end.
right.
So if you can just liaise with him to make sure that
Okay.
I would like to move to the next presentation.
Go ahead. Can I start? Hello.
Okay, can you see?
No.
You can upload it.
Yes. Yes. As I said earlier, so my name is Sanusi Musa. Now, since I have a limited time, let me continue. My topic is human parvovirus B19 infection prevalence in Africa, a 5-year contemporarous meta-analysis. These are my outlines. Introduction, non-enveloped DNA virus belonging to this family, parvoviridae, subfamily, parvovirinae. You can see the genus and look at the life cycle of the virus. It has about 8 stages. It was first discovered in 1975 by Brian Costa and his colleague in blood of 9 apparently healthy prospective blood donors and 2 patients. It originates, the name parvum originates from Latin, means small. It's associated with a variety of diseases such as erythema infectiosum in children, intrauterine death in pregnant women, as well as hemolytic anemia among adults. B19 infection are implicated worldwide, including one or the other African countries, and there is lack of a comprehensive and most recent review on prevalence in Africa. So that's the essence of coming up with this write-up. We conducted this systematic review and meta-analysis between 3rd and 24th January 2020. Comprehensive bibliometric studies were conducted on PubMed, Scopus, Google Scholars for English public articles between 2015 to year 2020. OpenMed meta-analysis version 10.10 software was used for the analysis. As you can see, the results after sorting out for eligible articles, we came across 10 eligible articles that are all cross-sectional studies. As you can see in this slide, it's supposed to be a meta-analysis of B19 infection in Africa. In West Africa, we came across 1 article that is eligible. Then in North Africa, 3 articles. In Central Africa, 2 articles. Southern Africa, 2 articles. In East Africa, 2 articles. So if you look at the laboratory method used by the researchers, we restricted ourselves to those that use IgG or those that use IgM as well as DNA. You can see those that use IgM, there's about 7 studies, 5 use IgG, then 4 use DNA as a method of laboratory analysis. Then the clinical presentations, we look at those that use, one study use acute febrile illness, then blood donors, 3 studies, 2 for pregnant women, and sickle cell anemia, 1 study, non-hereditary anemia, 2 studies, and 1 is among the neonates. As you can see, in this table, we are showing the viral markers that are used, as I indicated previously. For the 7 studies, we have this 1,775% group. Participant group represent 11.4%. Then those that use IgG, about 49%, and those that use DNA as about 16.1%. These are age
Clara?
Oh, is it me or is Sanusi?
No,
Sanusi,
no,
Sanusi's line has dropped.
Sanusi. Can I ask that we basically stop the presentation here and just get the next speaker, please? I apologize for that. If you can mute Sanusi, we'll just try and see how we can make the presentation available. Apologies. Oathokwa, please, you can introduce the next speaker. Apologies for that.
Okay, give me a second. So our next speaker is going to be Colleen Fant and Macrine Olwala, Pediatric Emergency Training and Academic Partnership in Kisumu, Kenya. Please go ahead, introduce yourselves and briefly, and then start.
Hello, everyone. My name's Dr. Macrine Olwala. I'm a medical officer at the Jaramogi Oginga Odinga Teaching and Referral Hospital. And I'm going to take you through this presentation. I'm just trying to share my screen. I am not, there we go, yes. Good. Okay, so sorry, trying to put a slideshow. Dr. Colleen, could you please assist me to do this? Let me just unshare to enable you to do that.
Okay. Is this work okay?
Yes, it is. Just please proceed with the slideshow.
All right.
Thank you. So I'm presenting on behalf of my very able team. Next slide, thank you. So our objectives for this presentation, one, to review simulation-based medical education as a novel educational tool. Secondly, to briefly describe how the pediatric medical education from Maseno University is ongoing at Jaramogi Teaching and Referral Hospital in Kisumu. Number three, I'm going to take you through how the curriculum on the simulation-based medical education was developed and implemented through the partnership. And fourthly, I'm going to take you through outcomes of the lessons learned after the implementation of the project. And fifth objective is to describe the next steps of the partnership. So next slide. So why simulation-based medical education? Well, first, simulation is widely recognized as an innovative tool in medical education, and it's used majorly to improve patient outcomes. So this happens by providing a safe learning space where learners can practice and make mistakes in a non-judgmental, no-consequence environment because of the use of mannequins. So secondly, there's active learning that goes on where the learning is self-paced and the learners can begin to marry theoretical aspects that they've been taught in class to active and practical management of patients. Thirdly, during this process, the learners get to receive real-time feedback where areas of improvement are identified and best practices are taught or reinforced. Fourthly, also diversity can be exploited fruitfully in these sessions because different cadres are drilled in different, with different agendas using the same skill set, so the same instructors, and then using the same simulation center environment. So this is quite comprehensive and very important, especially for pediatric emergencies that are less common, but when they occur, they carry a higher risk for these patients because if the correct intervention is not done as soon as possible, then the consequences can be quite grave. Next slide, please. So let me just take you through the key components of simulation-based medical education. So the first phase is a pre-brief phase where the facilitators usually introduce the learners to the simulation environment by letting them know, the safety of it and The learners are also introduced to the mannequins, the technology that is in the simulation center, their roles and what is expected of them during the scenario. The second phase is when the learners get to really interact with these mannequins, and they're reminded to do that as if the mannequin was a real patient. So hereby we have a designated instructor who provides solicited information to the learners, and also the monitors, if attached to the mannequins, can provide more information. Usually if there's a second or third facilitator, they take the role of an implanted facilitator who majorly ensures that realism continues during the simulation session, and then they can also provide rapid real-time feedback as the scenario is ongoing. So thirdly, the third phase here is the debrief phase, where the facilitator solicits learner-driven feedback by asking them how they felt during the scenario, what they think they did right, areas that they think they can improve on. And during this process, basically the instructor highlights the key learning points so that the agenda for the scenario for that specific case is gotten by the students. Next slide, please. So in the next few slides, I'm going to take you through exactly how we ran our partnership for this simulation session academic year. So just a brief introduction to the simulation center at Jaramogi Hospital in Kisumu. So the center was established in 2016, initially to support the training of nurse anesthetists. It is managed by a local NGO at this moment. It has a lot of technology advances there. So we have access to the internet, and then there's a mixture of low and high fidelity mannequins. If you look at the pictures there, there's an infant one, there's an adult on the second one, and a pregnant female on the last right picture above. So also there are patient monitors and a lot of medical equipment, including anesthesia machines, ventilators, etc. So a lot of healthcare workers, over 800 so far from Western Kenya, have been taken through through various simulation courses in this center, including ACLS and basic emergency courses. Next slide, please. So the more on how this partnership began, it was initiated in February 2020. It is a partnership between Northwestern University in Chicago, USA, and Maseno University / the Jaramogi Hospital, where their students are exposed to clinical practice. So the partnership began in 2020, and curriculum development started from there. And in this development, basically, there were 4 core competencies that were exploited. Basically, 1, faculty development, content development, pilot training, and training symposium. So we're going to go through the details of this in the next few slides. Next. So the curriculum began with the simulation pedagogy, where the Maseno University team was introduced to the concept of simulation, how to apply it. They were taught how to come up with learning objectives for the students, and how to develop various topics that were required for their undergraduate training. And they were also taught how to deal with different types of learners in that context. And next, there was case development, where the first 4 cases, as listed above, were gotten from the Northwestern team and were practiced on. And then thereafter, as the year went by, a total of 7 cases were developed with the latter 3 basically developed by the Maseno University team under the tutelage of the Northwestern team. So now that we had the cases at hand, we held 3 virtual practice sessions on the simulation, where the Northwestern team acted as learners and the Maseno University team acted as instructors. And this helped in mentoring the Maseno University team to get comfortable with becoming instructors. So they learned how to instruct, what to tell the students, how to help students who are a bit slow, etc., etc. And thereafter, the Maseno team, who were now trained in how to become instructors, practice facilitation with the 6th-year medical students at Maseno University. Hereby, a total of 6 sessions were done, basically 2 weeks apart, and after each session, there was a 10 to 15 minutes debrief session. Thereafter, we concluded with a 1 week long simulation symposium for all the graduating 6th year students. There were 15 number. So they were divided in 5 groups, and each group came to the simulation center for 1 day, and they had 3 cases per session. So all the learners participated in 1 case and observed and provided feedback to their peers and even to the instructors in the additional cases. Next slide, please. So we had 3 major outcomes at the end of the whole period. So between February 2020 and July 2021. So the first outcome was that 3 pediatric faculty at the Maseno University completed their training and were able to, and are currently able to facilitate simulation sessions very independently. So that was a great achievement. The second achievement was we had a total of 7 cases which were developed and modified for the Maseno University during this period. So the faculty at this point in time is able to develop their own cases and tailor them to some of the illnesses that we experience around this area, most of them. And thirdly, we had such positive feedback from both the students and the faculty that were created. The faculty reported that they had increased confidence in running simulation cases and being simulation instructors, and they appreciated simulation as a learning tool for their students. And on the other hand, the students also really appreciated the experience, encouraging the faculty to have even more frequent sessions as they're doing their final 6th year of medical school. So next slide, please. So currently, the plan that we have as Northwestern University and Maseno University faculty partnership, as we go on into the next academic year, we plan to continue the simulation sessions, basically have 1 to 2 sessions per month at the simulation center in Jaramogi Hospital in Kisumu. And we will continue to run the existing 7 cases for different cohorts of medical students. And also we will endeavor to add additional simulation cases that are sort of tailored to some of the endemic illnesses that are in our setup, including malaria, including Burkitt's lymphoma, and sickle cell disease, amongst others. Thank you very much.
Thank you.
Again,
yes, I wish you had more time, but very interesting. But thank you for sharing those lessons with us. We can take down the presentation. Let me invite Theresia Ambrose Ottaru to discuss ideal cardiovascular health. You can start putting up your presentation, please. Distribution, determinants, and relationship with health status among adults living with HIV in urban Tanzania. Please go ahead. Thank you.
Hi, everyone. My name is Theresia Ottaru, as I was introduced. I'm a faculty member at the Muhimbili University in Dar es Salaam, Tanzania. I'm also a PhD candidate in the NIH-funded grant called Building Capacity for Patient-Centered Outcomes Research to improve the quality and impact of HIV care in Tanzania. And this is the collaboration between the Institute for Global Health in Northwestern University and Muhimbili University. So today I'm going to present to you on cardiovascular health among people living with HIV in urban Tanzania. So as you know, cardiovascular diseases are the leading cause of death globally, and people living with HIV compared to the HIV uninfected individuals have the relative risk has been decreasing over time, and this is due to the increased availability of more effective antiretroviral therapy, but the overall or the absolute burden for these diseases is still high and increasing among people living with HIV. And this is because of several factors, including the traditional risk factors for cardiovascular diseases, combined antiretroviral therapy, and as well as the persistent HIV-associated immune activation. All these lead to damage to the blood vessels, causing several effects such as endothelial dysfunction and increasing the risk of cardiovascular disease. So we have an index called the Cardiovascular Health Index, which was developed by the American Heart Association, and it has been used to assess cardiovascular health in the general population. And it is said understanding of this index can help reduce the development of cardiovascular disease risk factors, as well as cardiovascular diseases in the future. So the index itself is based on 7 metrics, and the overall score ranges from 0 to 7. The higher the score means the better the cardiovascular health. So we have the 3 cardiovascular disease risk factors, as well as 4 health behavior factors. And it is a valid measure of cardiovascular health also in sub-Saharan Africa, and it has been shown to correlate and associate well with the common carotid intermediate thickness, which is a measure that's used to assess atherosclerotic changes in the common carotid artery. So we used this score, and we wanted to understand what is the distribution and what are the factors related to this score among people living with HIV. And we also wanted to assess if it's related with health status. As we know, people living with HIV already have a compromised perception of their health status due to the HIV-associated stigma and depression. And maybe cardiovascular health could be an area we could intervene to improve the perception of their health. So we involved 6 HIV clinics in urban Tanzania, and we included 629 HIV-infected individuals. And among these, we assessed their social demographic characteristics. We assessed their HIV infection-related factors. We assessed also other factors, including presence of comorbidities. We also assessed the cardiovascular health index metrics, and as well as the health status. So this slide shows the distribution of the metrics used in the cardiovascular health index. And here I wanted to point out the diet metric, which shows that to be at an ideal state, a participant needed to take 20 or more total servings of fruit and vegetables. This could be a hard target to achieve, especially in an urban setting. So we had a relatively old population with a mean age of 43.5. Majority were still in the first regimen with and have achieved virus suppression, have been living with HIV infection for 6 million years, and they had a pretty good perception of their health status. The overall score ranged from 5 to 25, and most of them scored 20.5. And out of our expectation, very few proportion of these participants were on any form of health insurance. So we thought that we have a very maybe a healthy HIV-infected population, which is stable on treatment. Looking at the distribution of the metrics, we can see that majority of the participants were at an ideal state for blood glucose as well as smoking, but the minority had an ideal state of diet. As I've said, maybe we used a very strict criteria. So sex-dependent metrics included smoking and BMI, and more females at an ideal state for smoking, while more males at an ideal state for BMI. Blood pressure, BMI, and diet had less than 50% of the participants at an ideal state. So with regards to the overall score, you could see that the study population had a pretty good distribution with a mean score of 4.5, and we did not see any significant difference between females and males. Looking at the proportion of participants with all 7 metrics at an ideal state, we found that less than 1% had all 7 metrics at an ideal state. We found that 52% of the participants had 5 or more metrics at an ideal state. So this category has been previously used to categorize. So this category has been previously labeled as participants with good cardiovascular health. So in our study, relatively 52% of the participants were at an ideal, had good cardiovascular health or ideal cardiovascular health. Looking at factors which associate with the cardiovascular health index score, we found that use of alcohol, having at least one comorbidity, and being aware that was associated with a significant lower cardiovascular health index score. And alcohol use was also a significant factor even after we did multiple imputation and even after we used the simplified score. The simplified score in this study was formulated from the user score, but we removed values for random blood glucose. We also removed values for total cholesterol, taking into consideration that not all HIV clinics in this setting will be able to do those tests in routine basis. So our findings.
Sorry, Theresia. Can you raise your voice a little bit? You're fading.
Okay. So our findings, and taking into account findings from previous studies, we see that achieving all 7 cardiovascular health, having all 7 cardiovascular health index metrics at an ideal state is a hard target to achieve. And this has been shown in several studies from all parts of the world. There was no difference when you consider a study population consisted of people living with HIV or HIV uninfected. All of them showed a similar results. And we found an average score of 4.5, which was within the range for studies which were reported from Sub-Saharan Africa. And this range was relatively higher compared to studies which were reported from other parts of the world, US, Asia, and Europe, suggesting maybe Sub-Saharan Africa will still have better cardiovascular health. And it could be that because of our health system, that's why we still have a higher burden of cardiovascular disease. And we suggested that primordial prevention for cardiovascular diseases among HIV-infected individuals in our setting should focus on advocacy for reduction of alcohol consumption, advocacy for reduction in development of comorbidities, especially hypertension, and should be more attention should be paid to people with old age. And we also thought that primordial prevention should focus on health education on increased consumption of fruits and vegetables, aiming at to control the BMI. In contrary to previous studies, we did not find any significant association between HIV-related factors and cardiovascular health. So when we looked at the relationship between health status and cardiovascular health, we do not find a significant association. And we think this is because we had a relatively healthy population, and majority of the participants had very good perception of their health status. And probably maybe because we use self-reported data and there were chances of desirability bias. But overall, most of the participants had a very good perception of their health status. So moving forward, the study was part of a bigger study that wanted to look at if we could integrate CVD care and HIV care for people living with HIV in Tanzania. So the first step was to assess the cardiovascular health, and we wanted then to assess the performance of HIV clinics in managing the cardiovascular disease risk factors. And here we're going to use the cascade of care indicators. So from these 2 studies, we identified participants living with HIV with cardiovascular disease risk factors, mostly hypertension and diabetes. And we're going to interview or assess their perception on their illness status, their treatment experience, including what has been the challenges in seeking care, and if they also have challenges with adhering to treatment for both HIV and the cardiovascular disease that they have, cardiovascular disease risk factor that they have. And we're going to focus on both those who are on treatment and also those who are not on treatments, and try to find out why those who are not on treatment, why are they not on treatment or any form of management. We're also going to interview providers and key stakeholders to understand their perspectives on what we can do to better the care for cardiovascular disease for people living with HIV. So with this, I'd like to thank the Global Health Research Catalyzer funding at Northwestern University for funding the study, and patients, HIV clinic staff, a team of data collectors in Tanzania, and also my mentors from MUHAS as well as Northwestern University. Thank you.
Thank you. Thank you very much, Theresia. Colleagues, it's really unfortunate we had such interesting talks, but there's no time to ask questions. We had hoped that the audience would use the Q&A session for questions, but we have to bring our our session to an end. And I must apologize to Sanusi Musa because he had some technical challenges. But we have, I think this was a really insightful session. I've personally learned a lot, and hopefully we've all learned something from this session. And congratulations on the researchers for the work and for the useful information that they have provided. Thank you, everyone. At this point, please can you share your slides, and I'm going to ask everyone please to put on your videos because the technical team wants to take a snapshot of this. So let's see. Fantastic. Yeah, there you go. Well done, everyone. Okay, so that's it. That's the session. Thank you, Professor Moshabela, all the way from Durban. That doesn't look very much like your university, but it's beautiful.
It is. Don't be jealous. It is. Thank you, everyone. Much appreciated.
Thank you. Bye.
On